Hello, this is Dr. Robert McMullen. I'm a psychiatrist in New York. I went to Georgetown Medical School in Columbia for my psychiatric residency, and I've been in practice almost 40 years, mainly doing psychopharmacology, but for 10 years I've been doing TMS, transcranial magnetic stimulation, which really adds to the benefit of medication and works in many people who've been quite treatment resistant. I want to talk about how many TMS treatments you need, how long before there's going to be a relapse, and then what to do about it. Generally, I want to talk about that. As an example, I'm going to briefly go over a case that another psychiatrist presented to a listserv questioning what to do to help this 55-year-old woman who has chronic depression and has been somewhat treatment resistant. She's had social isolation and low self-esteem, particularly in her teens. She had several years of psychotherapy, which she did not think were helpful. She had her first major depression after the first childbirth, which is common, a postpartum depression when the estrogen levels suddenly just drop hugely. It can precipitate a depression, and she was hospitalized. She was given an SSRI, serotonin medication, something like Prozac, Zoloft, Lexapro, Celexa. Most all of the new ones, except for Wellbutrin, are serotonin medicines. And it seemed helpful at first, but then the depression recurred. So it sort of pooped out. She had another hospitalization a little over 10 years later for 5 days. She had a third depression 3 years later at 48, and a fourth depression when she was 54. She underwent TMS treatment, 30 treatments, which was somewhat helpful, and the depression returned a few months later. She had one EC treatment as an outpatient and had severe headache and terrible jaw pain, so didn't return. Now, she's been on many serotonin medicines, including Effexor. She's been on the Wellbutrin. She's had many of the old tricyclics. And she's also had mood stabilizers like Lamictal, Tegretol, Depakote, and so on. She's really had quite a lot of medicine. At one time, somebody thought she might have bipolar disorder. The two things she really hasn't had is an MAO inhibitor, which is the most powerful antidepressant, and she should definitely have that. She's afraid of it because you have to be on a diet where you avoid certain foods, especially aged cheese. But it's all dose related. If you're going to eat a baseball-sized cheddar cheese portion, you're going to really have high blood pressure. With a size of a baseball, maybe you'll have a problem. But if it's the size of a golf ball, you may have a problem. Size of a quarter to a half of a golf ball, probably nothing would happen. So if there's a little of it mixed in your salad, you don't really have to worry that much. Also, you should just start out with a very low dose, just 10 milligrams for a week or two, and then go to 20. And often it works at 20 or 30. The maximum is 80. And the other thing she has been reluctant to try is lithium, which is a no-brainer that you have to take lithium. In the last 4 years, I've had 62 people who had a dramatic benefit from the lowest dose of lithium, 150 milligrams. Someone with bipolar 1 disorder, manic depression, they might need 1,200 milligrams a day. But for depression, low doses work. In fact, the high doses won't help depression. Only the low doses work. When they did studies on it, well over 50 years ago, they found that 900 milligrams worked very well as augmentation to add on to antidepressants. 900 milligrams is a hefty dose, and no one dreamed that low doses like 150 or 300 would work. And once you're on 150 for a month or two, you can always bump it up a little. And in any case, it prevents Alzheimer's. Anyone approaching 60 should be on 150 of lithium, especially if they have a history of depression. If no history of depression, then 1 milligram or 5 milligrams from the internet might work. It also seems to delay aging. You can look this up on the internet. Telomeres, T-L-O-M-E-R-E-S, are the ends of DNA, and they break off over time, which may be a major reason that aging occurs. Lithium prevents them from breaking off and repairs the ones that are breaking off and even extends them. So, for two reasons, to prevent Alzheimer's and to delay aging, and the third one is to prevent depression, lithium is very important. Now, when people with depression have double the risk of Alzheimer's, the people with manic depression, bipolar 1 disorder, have 7 times the risk. And lithium brings their risk down to the same as the general population. Now, with this lady, someone who thought she might have bipolar disorder is probably right. She probably has mild bipolar disorder, just mild highs, although it is not mentioned whether she has atypical symptoms. If you have atypical symptoms in some of the past depressions of oversleeping, sometimes carbohydrate craving, and rejection sensitivity, and a lot of mood reactivity, like something good happens, very good, it might really lift your mood, and bad things will just plummet you. And the rejection sensitivity is if your spouse, assuming you respect your spouse, criticizes you a little bit for a mistake you made, you are really hurt. And for the rest of the evening, you're thinking about it. Anybody who poops out on serotonin medicines is generally in that bipolar spectrum. Their highs may only be that once in a while they become very enthusiastic about a new hobby and they start searching on the internet to find out what type of golf clubs to obtain or other things related to their new endeavor. They may not get into any trouble with this mild high, and nobody thinks anything of it, so you can't really diagnose it as an illness. It's not bipolar 2 disorder with highs and lows, with milder highs and lows, because these are so high that they don't cause trouble, so they're not a diagnosis. But they do mean the patient is in a bipolar spectrum. And in any case, anyone with treatment-resistant depression should have TMS. Oh, I forgot one thing. She had 30 treatments of TMS with significant benefit. I don't know if she came to euthymia. And then she relapsed a little. She did relapse 3 months later. If she improved a lot, then she should have kept going until they really brought her all the way to normal. Whether it's medicine or TMS, you want someone to come to normal with no residual symptoms. If they have residual symptoms, it raises the risk that they're going to relapse within a year. But if you get them to a point with no symptoms, you may be able to keep them there for years using the right treatment. Now, since she had TMS and it was somewhat successful or a lot successful, when she relapsed, if she had gone in for treatment it would not be for another 30 treatments. 5 or 6 treatments, and she would be back to where she was after the 30 treatments. This is the same whether it was a moderately good benefit or 100% benefit. The amount of treatments varies a lot. All of the studies just do 30 treatments and then they stop. Why? Money. It's very expensive to do these treatments. So it's become the standard for research to do 30. Now, at the end of 30, 1/3 of patients have zero benefit, no benefit at all. 1/3 come all the way to normal, and 1/3 are not all the way to normal, but they're improving. And at the end of the 30 days, their graph of their depression scores is still going down for the various tests for depression. Having a 1/3 complete remission rate, and I've had many patients who became normal for the first time in their life after 30 treatments, is phenomenal. Once you've tried all these medicines and nothing has worked all that well, or not at all, the odds of you finding the next medication working so well that you come to a completely normal mood is extremely low. Well less than 5%, if not 1% or less. So a completely different modality is indicated. The 1/3 who are improving, if their scores are going down steadily at the end of 30 treatments, that implies that if you keep going, many of them will come all the way to normal. The first 75 patients we treated had about a 60% remission rate, not 1/3. Many of these people had 50 treatments or more. So having a very long course of treatment is probably necessary in a lot of people. The TMS practitioners should probably reduce the fee a lot after 30 treatments in order to induce the patient to keep going and bring them to normal. Now, what happens with relapses? It is so variable, so variable. I had a professional man who was 58, who was the first patient I had for TMS. In fact, I almost bought the machine for him because there really was not any other option. He had been mildly depressed in his 20s and more depressed later, and had done relatively well on an MAO inhibitor, the one you can't eat cheese with. Then the last 2 years, he just had tremendous depression, and a very good psychopharmacologist didn't get anywhere with him, and neither did I. And he became a little delusional, thinking he hadn't learned anything in his specialty in 5 years, that he was totally useless, that he would be fired. We were worried about him being fired because the depression made him so dysfunctional. After 30 treatments, he became completely normal. This was amazing. He was, for the first time in his life, normal. Now he could schmooze with clients and do a really good job of supervising people underneath him. And if he had been like this for the last 20 or 30 years, he would have been a partner instead of a senior person in his firm. This normality lasted 3 months, and then he began having moderate relapses. And every time he started to go downhill, he would come in and get 1 treatment or 2 treatments and be back to normal. This went on for 9 months. So he had 30 treatments, 3 months of normality, 9 months of touch-up treatments, and it totaled 50 treatments. Then he didn't relapse. He went for almost 3.5 years, completely normal for the first time in his life. His family was pretty amazed. And then he had a relapse and we had to treat more again. Another dramatic example was a young woman I treated from the age of 20 to 42, 22 years. And there was another good doctor that treated her for 2 years in there. She had so many different diagnoses. She had generalized anxiety disorder, she had panic attacks, she had obsessive compulsive disorder, chronic depression, and an eating disorder where she restricted herself to 115 pounds. Then at 42, she went into a major depression, a really severe one, and came right in, partly because a relative of hers had done so well with me. It only took 14 treatments, and she became normal for the first time in her life, which was quite amazing. And over the next year, I think she needed 4 more treatments. Every 3 months, she'd start dipping and come in and get one treatment, and it would bring her out of it a few days or a week later. She had a total of 18 treatments. And then over the next 3 years or so, her problems gradually went away. Something would go away, she'd be on another plateau. Her parents told me about this, they were pretty surprised. And then one day she came in and I asked her about the depression, none. The anxiety, no more. She had great problems falling asleep because when she had all the anxiety, she'd worry about the next day and then she couldn't fall asleep. And everything cleared up. It was amazing. The eating disorder even cleared up. She said, well, I weigh 145 pounds, and that's okay. It was astonishing. I have another patient who also had 5 or 6 diagnoses for many years, and she also went into complete remission. And Dr. Downer, a great researcher in Toronto, he says this happens on rare occasions, that someone with multiple problems will remit. With someone like this, you never, ever expect them to come all the way to normal. You treat them with antidepressants, anti-anxiety agents, and so on, and you really take the edge off. Sometimes they function fairly well, but you never expect them to come all the way to normal with medication. He thinks that it is because the TMS is altering the cingulate gyrus. There's gyri up here on the surface of the brain where we do all the thinking, but there's a second layer under here called a cingulate gyrus. There's also underneath here, you can't see it, is a second layer called the insula. In the salience network of the brain, both of these nodes are dysfunctional in every psychiatric illness. So he thinks that may be why in some people treating this is part of the reason that all their problems clear up. And that makes some sense. The salience network is one that pays attention to things that are salient, that really are important and pop up. The executive network is a loop of thinking that deals with routine tasks that you do, like going over a business ladder and correcting it, or working in a factory and doing even complicated things. And the default network is what happens when we're not doing anything. We're just sitting back and daydreaming about playing tennis this week, or thinking about a number of different things. And the salience network is called in during circumstances where there's a problem. Like whatever you're doing, suddenly there's something in it that is really critical that you have to deal with, or you have a moral problem that you have to wrestle with. And that's the system. And that system seems more involved in psychiatric disorders than other systems. In any case, whatever the cause, these TMS treatments work. And interestingly, a guy named Yitzhak Roth in Jerusalem, a brilliant physicist, developed a TMS helmet where there's coils that go all through the helmet, and the magnetic field goes much deeper than the standard figure-8 machines. And so it reaches the cingulate gyrus more effectively. I'm not sure that it is more effective for depression, but it seems like it may be more effective for OCD, which is probably rooted in this area as its etiology. There are quite a few places to treat now. The left prefrontal cortex is the one that's been done for 25 years or so, but the right side works too when it's inhibitory. Then people who emote a lot, they're very depressed, but they still have a lot of emotions. They get angry, they get upset, they cry, and are all over the place compared to their norm emotionally. If you treat them on the dorsal medial prefrontal cortex, which the OCD helmet from Brainsway does, it seems to work better for them and their emotional swings and depression. Now, when you're thinking of doing something risky, like go tell your boss what you really think of her, or go paragliding, or anything risky, I guess you're thinking up here, but there's input in the right orbital frontal cortex coming up saying, wait a minute, let's be cautious. And these people are usually quiet, a little obsessive compulsive in style, even though they may not have OCD. So they have more input that is adverse to risk. And that may be causing the depression. So if you do inhibitory treatment here, it can help depression and or OCD, especially in these people. So there's a way of predicting what area to work on with the TMS. Again, I can't overemphasize this. If one has very good benefit with TMS and then relapses, it doesn't matter. That means if you go back and do a few more treatments, you might bring them to normal. They just need more treatments. You need to follow Willie Sutton's law. He was a bank robber in the early 1900s. When they finally caught him, the journalist went to his jail cell and asked him a question. Willie, why do you rob banks? And he said, because that's where the money is. So in medicine, we say that. If the only thing that ever really worked in the patient is TMS, you should go where the money is and do it more times. One very early patient was somebody I had treated since she was 14 for mild depression. And at 27, she had a severe depression where she couldn't stop thinking about suicide. It was really painful. So that night, we started her on TMS. And after 30 treatments, even 27 treatments, she was pretty much back to normal. In fact, she felt better than she ever felt. But 2 days later, she'd be back in this suicidal depression. So I had to keep on doing 2 treatments a week just to keep her head above water, and I was worried whether I'd have to do this the rest of her life. I just looked over the case a couple days ago. Because when the depression recurred, so did the suicidal ideation and feeling terrible. Then at 4.5 months, she stopped relapsing and stayed normal. About 4 months later, she relapsed, came in for 1 treatment, was back to normal. After that relapse, she went 3.5 years completely normal in mood for the first time in her life, and she was very grateful. Then she had a moderate relapse. She was going downhill. She came right in and had 5 treatments, was completely normal again, and then went another 3.5 years completely normal. So she had 7 years of euthymia with 1 2-week interruption where she needed 5 treatments. When she relapsed after the 7 treatments, a medication adjustment worked to bring her back. It's really a fantastic treatment, and it's underused, and I can't believe how some people and their doctor want to go to ECT without doing this. I had one patient who had this 5 or 6, the other one I mentioned, 5 or 6 diagnoses that all cleared up. She'd had these since she was in the 1st or 2nd grade, and she was 29. It was astonishing. She had a lot of treatments, 75 sessions, usually 4 or more treatments per session, 4 or 5 treatments in different places on her head. And then she was completely normal. And she remained that way for 3 months until her family insisted she reduce the antidepressant. A complicated story. And she relapsed a little, but she was able to hold a full-time job for the first time in her life. And I was told a couple of years later or something that when she relapsed, she relapsed a little more severely, she went in and had ECT, which had no benefit. If you have a choice between ECT and TMS, and the TMS worked really well, what would you choose? The problem with TMS is it's a little dangerous. You're under anesthesia. On rare occasions, it can permanently ruin your memory. And it interferes with your life because the day of the treatment, you can't do anything. It's usually 10 treatments. Another problem, which Harold Sackheim, a prominent person in ECT and TMS, said, is that after a year or so, frequently the person relapses into major depression and they need another 10 ECT. Whereas with TMS, the effect is much more durable. When you relapse, you don't need another 30. You need just a few, usually, to bring you back to normal. And sometimes you'll go 3 years or more without a relapse. We expect relapses because depression is a chronic illness. Is there anything else I should say, Zvi? Okay. Thank you very much. This is Robert McMullen, MD, in New York City. And please keep trying to find something that works. There are so many things one can try, and there's many proven things. For example, NAC, N-acetylcysteine, which is really a food. It's one of the 20 proteins that makes up our body. Thank you very much, and have a good day.